करा या श्वेत पद्मासना या निशेष जाड्या पहाड
Good evening, one and all. Welcome to this webinar. I would like to thank all of you for accepting our invitation to join us over here. And I'm sure that your august presence and active participation during today's virtual webinar will further augment the success of this meeting. Doctor, you have always garnered trust and warmth upon us, and we seek the same in future as well, especially during this period of uncertainty. With that, let me introduce me today our webinar speaker. He is none other than Dr. Professor Soumitra Kumar. He is a very senior cardiologist from Calcutta. Dr. Soumitra Kumar is a professor and HOD Department of Cardiology from Vivekananda Institute of Medical Science. He is a chief coordinator in Ardentega International Institute of Cardiology, Calcutta, and he is also a consultant cardiologist in Fortis Hospital, Calcutta. And he is going to talk today with a very interesting topic: is the brain in hypertension. With that, I welcome Dr. Soumitra Kumar. Sir, welcome to this webinar.
Thank you.
And I
Thank
hand
you,
over the
Vantraj
session to
and
you.
team of Torrent. It is a privilege and a pleasure for me to address today's webinar on this very kind of unusual topic, the brain in hypertension. You may be wondering why I have chosen such a topic mainly meant for neurologists. But hypertension is, of course, one problem which involves uh, cardiologists, neurologists, nephrologists, and all physicians, in fact, because it involves all the organs in the body if it is uncontrolled. So that is my theme of presentation today, the brain in hypertension. Mr. Prosenjit, can I have the slides, please? Yes, thank you. So, good evening, ladies and gentlemen, my esteemed colleagues. The topic I have already mentioned, the brain in hypertension. Next slide, please. Next slide. Mr. Prosenjit, next slide, please. Yeah, make it full screen and start sharing. Yeah, next slide, please. Yes, thank you. So hypertension is known to all of you is a lifestyle disorder. It's one of the major risk factors for cardiovascular diseases. And as I mentioned that its main uh, target organs are brain, heart, the blood vessels of the body, and ultimately the kidneys. So if one has uncontrolled hypertension, the end result is stroke, myocardial infarction, vascular disease, and chronic kidney disease. The prevalence is mind-boggling. The estimated global prevalence of hypertension is 1.13 billion. That is almost 1/6 or 1/7 of the entire population on Earth. And in the Indian perspective, we being a country of 1.3 billion or more, we have a prevalence of hypertension in the tune of 30%. So you can say almost 40 crore people in India are afflicted with this disease. So a huge problem. Next slide, please. Next Mr. Prasenjit?
Sanjit, please next slide.
Yes, I'm trying, but something is going to problem. Just I'm trying 1 second, sir. Next. Next slide. Sir, problem check. Yes, sir. Yes. Okay. So hypertension is a silent killer, as it is said, and it is the biggest global silent killer. And the main problem with hypertension is that it is silent. So many of the patients tend to worry. I mean, tend to think that why should this problem be treated at all? I have no symptoms, doctor. But the main problem with hypertension and to some extent with diabetes also, and dyslipidemia for that matter, yes, are the things that these are all very silent problems. They ruin the body from inside and cause enormous problems, some of which I've already highlighted. And again, they are highlighted in this slide. Next, please. So this is the, I mean, very notable quotation by Welton. Uh, I quote, "You have already doubled your risk of cardiovascular complications compared to those with a normal level of blood pressure." Unquote. Next slide, please. So hypertension is the leading cause of global cardiovascular morbidity and mortality. Yet it is a condition which can be diagnosed very easily with a simple blood pressure measuring device. Of course, it has to be reliable. Uncontrolled hypertension promotes target organ damage and significant disease burden on the community. And it is responsible for no less than 45% of deaths due to heart disease and 51% of deaths due to stroke. Given that stroke accounts for largest share of neurological burden of the disease, hypertension is increasingly being recognized as a global neurological problem. And I will put in perspective the fact that only 8% or so of Indian population has controlled hypertension. So you can imagine the enormity of the problem in India, so that almost 30 crore or 25 to 30 crore population, Indian population, is at developing stroke at any point of time because hypertension in them is absolutely uncontrolled. Next slide, please. Hypertension affects more than 1 in 4, or I would say 1 in 3 individuals. I've already told you the prevalence in India is 30%, and brain is one of the organs which is affected very early, and it may manifest as stroke or subclinical cerebrovascular abnormalities, and ultimately dementia, as I'm going to show you. Hypertension related small vessel disease can cause vascular dementia and can potentiate Alzheimer's pathology, lowering the threshold at which signs and symptoms manifest. I will elaborate on this point later on. Many hypertensive emergencies may also have a neurological presentation, such as hypertensive encephalopathy, hemorrhagic stroke, or preeclampsia or eclampsia. Next slide, please. So, is hypertension a neurologic disease? Because it is pertinent to ask this question because brain plays an important role in blood pressure homeostasis. The cardiovascular center in the medulla oblongata is responsible for the regulation of the cardiac output. Of course, it is not bereft of control because higher centers in the brain, as I'm going to show you, have control over medulla in this regard. Brain is involved ultimately in the short-term control of blood pressure by mediating changes in heart rate, stroke volume or vascular tone, and via sympathetic and parasympathetic stimulation. Whereas renal regulation is more important for long-term control, and hence renal denervation has ultimately become a target for chronically uncontrolled hypertension. Next slide, please. So the rostral, ventrolateral medulla, and upper cervical spinal cord regions play a key role in central BP control. For example, any patient who has sustained a high cervical spinal cord injury is associated with a very erratic BP, dysregulated neural network dynamics in caudal pressure regions have been implicated in the development of hypertension. And as I said, there is control of the higher brain centers also on the medulla, like from the cerebral cortex, from hypothalamus, and from the limbic system. Next slide, please. So the pathophysiology of hypertension-induced brain injury is that at ages between 40 to 69 years, each difference of 20 millimeter mercury in usual systolic blood pressure uh, or approximately 10 millimeter in usual diastolic blood pressure is associated with more than a twofold difference in stroke mortality. Hypertension also worsens stroke outcomes as patients with pre-existing hypertension have smaller penumbras and larger infarctions compared to those with normal blood pressure. Now, cerebral blood flow in a normal brain is determined by various intrinsic controlling mechanisms like myogenic stretch or chemical, metabolic, and neurogenic control. Fortunately, we have some measure, some safety measures in the form of autoregulation in the brain, which ensures that cerebral blood flow remains relatively constant over a wide range of blood pressure changes. Whenever these extremes of blood pressure occur in our body, uh, these exceed the compensatory vasoconstrictive or vasodilatory capacity, and thereby this autoregulation is impaired. Next slide, please. So here you can see that for a normal brain, there is a cerebral autoregulation mechanism between mean arterial pressures of 50 to 150 millimeters of mercury, a wide range of blood pressure. Now, this curve is shifted to the right in hypertensive population. In hypertensives, this comes into play, for example, between 70 to 180 millimeters of mercury, in some cases, even up to 200 millimeters of mercury. So, the hypertensives have a greater safety measure as far as autoregulation is concerned. But despite that, adaptive mechanisms which are forwarded by the internal milieu, if a patient has a particularly unregulated, uncontrolled blood pressure, this cerebral autoregulation mechanism is overwhelmed, thereby various cerebrovascular accidents occur. Next slide, please. The pathophysiology of hypertension-induced brain injury. So as I mentioned, it is safe to have a mean arterial pressure between 50 to 150 in a normotensive person. For a hypertensive, this still holds true for a higher BP values, as I said, between 70 to 180. But there are times when these autoregulation mechanisms can be overwhelmed or overcome. Thereby, it is, a cerebrovascular accident occurs. How this autoregulation is maintained? It is a combination of myogenic tone alterations or inward vessel remodeling with an increase in wall to lumen ratio in response to tangential stress on the arterial wall. Next, please. Continuing with pathophysiology of this hypertension-induced brain injury. Now, angiotensin 2 and aldosterone have been known to be linked with the production of reactive oxygen species. I'm going to elaborate again on this. So thereby this means that if we use angiotensin receptor blockers or aldosterone antagonists, we can give some protective mechanism to the brain. Now, how do these reactive oxygen species act on the brain? They cause vessel rarefaction. That means loss of arterioles and capillaries. They cause structural remodeling of cerebral blood vessels, and they are associated with chronic hyperperfusion of the brain. Now, hypertension also enhances blood-brain barrier permeability via reactive oxygen species and impairs its ability to regulate central nervous system homeostasis. Now, it is not only the angiotensin receptor blockers or ARBs or aldosterone antagonists, the ACE inhibitors also tend to produce, tend to provide some kind of protection to the blood-brain barrier and protects its permeability. Next slide, please. So, what should be the BP targets in the various hypertensive emergencies so that we can avoid more of brain damage? Now, the main point to be understood is that blood pressure management in hypertensive emergencies involving brain, be it hypertensive encephalopathy, be it intercerebral hemorrhage, or acute ischemic stroke, one should consider that the pathophysiology is unique to each condition. So management should be tailored according to the disease, and there is not a single recommendation that fits all. So no size fits all. Consequently, the right diagnosis is crucial based upon the clinical features, brain imaging, neurovascular evaluations, and cardiac tests. Now, let's first talk about hypertensive encephalopathy. Now, the diagnosis of this condition is based on the presence of one or more of these features: vague neurologic symptoms, headache, confusion, visual disturbances, seizures, nausea, and vomiting. The onset of symptoms usually occur over 24 to 48 hours with neurologic progression. Complications can result in neurologic deficits from intracranial hemorrhage. Focal neurological lesions are rare and should raise the suspicion of stroke. Next, please. Now, symptoms are usually reversible with prompt initiation of antihypertensive therapy. It is usually safe to reduce mean arterial pressure by 20 to 25% and to lower the diastolic blood pressure even up to 100 to 110 millimeters of mercury using labetalol, nicardipine, or nitroprusside. But agents that affect the CNS, such as clonidine, reserpine, methyl dopa, and diuretics, should be avoided. There is a special condition we have come to know about is PRESS, posterior reversible encephalopathy syndrome, which has been increasingly recognized as a complication of hypertensive encephalopathy. Now, findings from brain MRI, I'm going to show you an image in the next slide. It shows symmetric hyperintensities in the subcortical white matter of the posterior temporal and occipital lobes in the fluid attenuated inversion recovery sequences of MRI. Some patients can also present with strings of beads and focal vasodilatation, vasoconstriction areas in cerebral angiogram, a finding compatible with reversible cerebral vasoconstriction syndrome. However, please remember that PRACE is a condition which, apart from acute hypertension, can also occur in persons receiving immunosuppressive drug therapy, after organ or bone marrow transplantation, and also in patients suffering from severe sepsis and multi-organ failure. Next slide, please. So these are the typical MRI images one obtains from a patient suspected to have developed PRESS. It is, as I said, the name suggests it is a reversible situation where the clinical syndrome usually resolves within a week of initiation of appropriate therapy, namely the anti-acute hypertension control. And the MRI findings also resolved in the course of days to weeks. Next, please. Now, coming to the next problem, that is ischemic stroke. Acute ischemic strokes occur due to occlusion of an intracranial or cervical artery with consequent deprivation of blood or oxygen to a particular brain territory. In the acute phase of ischemic stroke, early initiation or resumption of antihypertensive treatment is indicated only in patients treated with recombinant TPA if hypertension is extreme. For patients eligible for IV thrombolysis, one targets a blood pressure of less than 1/85 upon less than 110 diastolic, or within the first 24 hours, even lower down to less than 180 by 105. The benefit of acute blood pressure lowering in patients with acute ischemic stroke who do not receive thrombolysis is uncertain. If the patient is not receiving thrombolytic therapy, one should not So acute ischemic stroke, it occurs. The next slide, please, Prosenjit. I've finished with this. So rapid reduction of blood pressure even to lower levels in the hypertensive range can be detrimental. So in the acute ischemic stroke, as far as acute blood pressure control is concerned, we should observe some kind of masterly inactivity unless one is planning thrombolytic therapy. Other than that, if the blood pressure is more than 220 by 120, one can initiate some antihypertensive therapy to reduce the blood pressure to the extent of 15 to 20% and no more. But other than that, up to 72 hours, one should not attempt to lower the blood pressure. In a very stable patient, one can make a uh, very cautious attempt at lowering blood pressure in the first 24 hours. But the general rule is that within first 72 hours, if one tries to lower blood pressure in a patient of acute ischemic stroke, he or she will be probably doing more harm than good. Next slide, please. Now coming to the third entity, that is hemorrhagic stroke. Now, spontaneous or non-traumatic intracerebral hemorrhage is the second most common cause of stroke after ischemic stroke. The most common causes are hypertension, bleeding diathesis, amyloid angiopathy, drug misuse, and vascular malformations. In patients with intracerebral hemorrhage, blood pressure is often elevated and hypertension is linked to greater hematoma expansion, neurological deterioration, and overall worse prognosis. However, the management of hypertension is complicated by competing risks. So on one side we have uh, the benefits of reducing cerebral perfusion pressure. On the other hand, we have the problem of intracranial hypertension. So in the face of intracranial hypertension, we should not try to lower blood pressure too much, otherwise cerebral perfusion pressure will diminish. And the potential benefits is of course to reduce further bleeding. Against this background, let us see what are the attempts at lowering blood pressure in hemorrhagic stroke. What are the trials showing? Next slide, please. So intensive blood pressure lowering to less than 140 millimeters of mercury systolic in patients with intracerebral hemorrhage had no clear benefits on clinical prognosis. That is the sum total of all trials. But once recent large randomized trial has shown that it was safe and associated with a modest better functional recovery. However, more intense blood pressure lowering to even less than 120 not only did show absence of clinical benefits, but it was rather associated with more renal adverse events in another clinical trial using IV nicardipine. A subsequent study in which systolic blood pressure was immediately reduced from a mean of 200 millimeters to two different targets of 140 to 170 versus 110 to 139 again showed that more intensive blood pressure lowering had no benefit on disability or death and was associated with more renal adverse events. Next slide, please. Now, intracranial pressure, as I told you, is an important parameter to be considered in patients with ICH. If the SBP is more than 180 and there is evidence of or suspicion of raised intracranial pressure, it is recommended to keep cerebral perfusion pressure at 61 to 80 millimeters of mercury. If there is no evidence or suspicion of elevated intracerebral pressure, a modest reduction of blood pressure to around 160 by 90 is recommended. If systolic blood pressure is 150 to 200, acute lowering to 140 millimeter of mercury is probably safe. Drugs that cause prolonged or precipitous decline in blood pressure should be avoided. Next slide, please. Next slide, Prosenjit. Next, please. Not moving, sir. Yeah. So this is a classical MRI image from one patient who has sustained a hypertensive hemorrhage. It is in the left basal ganglia. So you are all aware of these kind of images in patients with ICH, and this one has extended even to the left lateral ventricle. Next slide, please. Now, this is another entity we have progressively come to recognize, that the patient dies not only of the effect of the intracranial hemorrhage, there is something known as secondary brain insult. And what are the components of secondary brain insult? The patient has fever, hypotension, hypoxemia, hyperglycemia, electrolyte disturbances, and acid base imbalance. The net result is a further increase in intracranial pressure and further decrease in cerebral perfusion pressure. And the resultant is entire brain ischemia and oxygen deficiency, progressive cell death, and ultimately this tends to come in a vicious cycle. We have secondary brain insult, and finally it becomes fatal. Next slide, please. So this is a master slide showing what should be our approach for control of blood pressure in the acute phase, and also for chronic phases for primary prevention and secondary prevention. I have mostly mentioned about the acute blood pressure regulation. I'm not going to repeat that. Overall, for primary prophylaxis, one should target a blood pressure of less than 140 by 90, but if it is well tolerated, one should go down to less than 130 by 80 as per the most recent guidelines. For secondary prevention, one has to be little cautious. The initial target should only be less than 140 by 90, and probably later on one can be little more ambitious, particularly if the patient has had a lacunar infarction, one should target a systolic blood pressure of less than 130. Next slide, please. Now, what are the diagnostic studies one should carry out in a patient of suspected hypertensive emergency? One should take a meticulous history from the patient, inquire about pre-existing hypertension, current treatment, whether patient had discontinued drugs, whether patient had taken recent counter over-the-counter medication like NSAIDs, sympathomimetics, or patient has recent corticosteroid use, or patient has some drug abuse, like kind of drug abuse like cocaine, and whether the patient is suffering from comorbid conditions like kidney disease or renal artery stenosis. So, quick history taking has to be there in any hypertensive emergency. Next slide, please. Then one should also do a quick examination also. Now, examination of all the pulses, blood pressure in both the arms, and then look for quickly for signs of heart failure, because patient may not come with only a brain emergency. The concomitant heart emergencies like heart failure or myocardial infarction can also be there. One should do a detailed neurological examination of fundoscopy. Don't forget about it. Most of us don't carry a fundoscope these days. One should take a look at the ECG, and if uh, situation permits, one should also do a urine analysis. Next slide, please. Then one should try to exclude concomitant cardiac injury, as I said, by doing a troponin, peripheral blood smear, chest X-ray, transthoracic echo. These are baseline tests. And after all, CT and MRI brain are the cornerstones of investigation. CT angiogram of thorax or abdomen, because if the symptoms suggest, one has to exclude acute aortic dissection also. A renal ultrasound for post-renal obstruction, kidney size or asymmetry should be there. And ultimately, this should not be done in an emergency situation, but if the blood pressure has really been uncontrolled despite the patient being compliant, one should look for the causes of secondary hypertension in a given patient. Next slide, please. So again, these points have been mentioned by me, what should be our approach for various strata of blood pressure and according to the situation. Now here you see that for the overall guideline is that overall we should not be very aggressive. Now we can be little more aggressive in hemorrhagic stroke, where we can target a blood pressure lowering of 20-25% of the mean arterial pressure, provided there is no raised ICP, where we should be even less aggressive. In acute ischemic stroke, do nothing for the first 72 hours. unless the blood pressure is more than 220 by 120. So these points I have already highlighted. Next slide, please. Now I am coming to a totally different aspect of the problem. This concerns us very much in our day-to-day clinical practice. And this is a very useful article. You can all note down the reference and go through it if possible. Neurovascular and cognitive dysfunction in hypertension. And this is a masterly article published in Circulation Research. Next slide, please. Now, we only study the large arteries of the neck. We look at their stiffening, remodeling, hypertrophy, and atherosclerotic plaques by a carotid Doppler study. But what we fail to understand that hypertension does not spare arteries at any level in the brain. It affects the pile arteries, it affects the penetrating arterioles. The pile arterioles undergo remodeling, hypertrophy, and microatheroma. The penetrating arteries which arise from the pile arterioles, they also suffer from microatheroma, microinfarcts, and even micro bleeds. The net effect is white matter damage. These are in the form of lenticulostriatal lipohyalinosis, microatheroma, and lacunar infarction. So this is how cerebrovascular anatomy and segmental pathology is affected by long-standing hypertension. Next slide, please. So I had told you about the effect of reactive oxygen species. So hypertension, you see, uh, uh, singularly promotes both the things. It causes oxidative stress and inflammation. And these put together, both oxidative stress and inflammation, cause to disrupt the blood-brain barrier. They disrupt the neurovascular units, cause their dysfunction and damage. And there is a specific subset of oligodendrocytes which look after the white matter health and the vascular health in the brain. This hypertension causes dysfunction of those oligodendrocytes. The net effect are altered tissue homeostasis, hypoxia, ischemia, reduced clearance of the toxic materials, and demyelination and faulty remyelination. And the end result can be studied on MRI images as white matter lesions. Next slide, please. And we have always thought of Alzheimer's disease as a isolated primary neurodegenerative disorder, but we are progressively learning that similar to vascular lesions we see in hypertensive patients, such vascular lesions are also seen in Alzheimer's disease patients. So these two are interlinked. Now, this amyloid plaques result from the breakdown of amyloid precursor proteins by some secretases. Now, in a patient of hypertension, as an increased activity of the secretases, thereby more amyloid plaques are created. We have less of neurofibrillary tangles. This occurs in a vicious cycle, and ultimately, both the pathologies, the primary pathology of hypertension and Alzheimer's disease act together to cause ultimate severe brain dysfunction, which manifests as severe dementia. Next slide, please. So these are the typical white matter lesions that we see in a patient who has uncontrolled hypertension for a long period. So on the left-hand side, we see a small white matter lesion. In the middle, we see a more moderate kind of a lesion. And on the right-hand extreme, we see a severe white matter pathology that has resulted from severe uncontrolled hypertension. Next slide, please. So, what are the outstanding questions and future prospects? Is the neurovascular dysfunction induced by hypertension sufficient to cause cognitive impairment? When does the antihypertensive therapy need to be initiated to minimize risk of cognitive impairment? Are there individuals specifically susceptible to the cognitive effects of hypertension, and in whom more aggressive therapy might be warranted? What class of antihypertensives is the most effective for prevention of cognitive impairment? Next, please. A growing body of evidence supports the biological importance of renin-angiotensin system and points to the potential importance of drugs within this family for dementia prevention in individuals with hypertension. The ongoing heart study heart ECG, age risk factor, and troponin. Phase 1B randomized control trial will evaluate the RAS system specifically in non-demented adults at risk for Alzheimer's disease, in which participants will be randomized to placebo versus one of the two dosages of telmisartan. Next slide, please. So, to conclude, ladies and gentlemen, the key take-home messages are: the brain may play an important role in causing and maintaining hypertension. Clinical manifestations of hypertension-related small vessel disease include stroke, depression, gait disturbance, cognitive decline, and ultimately dementia. The strongest evidence that hypertension is a risk factor for dementia and cognitive decline comes from the observational studies with mid-life measures of blood pressure and late-life measures of cognitive performance. Hypertensive emergencies often have a neurological presentation like hypertensive encephalopathy, ischemic or hemorrhagic stroke, and preeclampsia or eclampsia. Hypertensive disorders of pregnancy are associated with increased long-term stroke risk, cognitive complaints, and white matter disease, as I have shown on MRI. Hypertension is common in obstructive sleep apnea, which is in turn associated with incident stroke risk. It is under-recognized condition following a stroke. Next slide, please. Neurologists frequently bear witness to the consequences of untreated and uncontrolled hypertension in the form of acute stroke or loss of memory, or in the sleep clinics in the form of OSA, and more rarely in the emergency department with the patient with encephalopathy or a stroke. Early diagnosis of hypertension with regular monitoring and treatment is the key and is absolutely essential to promote and sustain brain health. Thank you very much for your patient hearing.
Thank you, sir, for an excellent, insightful, and lucid presentations. Now, so a lot of questions have come from different parts of India in the chat box. So I'll take the question one by one, sir.
Sure.
The first question which has come is, sir, what is your opinion on newly introduced CCV like azilidipine useful for the treatment of hypertensive patient with post-ischemic stroke?
I'm yet to gather a lot of experience with this molecule because you see, with 3 months of lockdown, I didn't have a chance to use this newly introduced molecule. To be frank, I am just contemplating beginning to use this molecule, but I don't know what my experience will be. Time will show. But right now, I'm not in a position to give you any kind of advice. So I don't have much experience with the use of this molecule.
Fine, sir. So next question is very interesting question. Any comments on hypertensive stroke or hemorrhagic cases increased or decreased during COVID-19 outbreak? Your opinion and your experience, sir.
No, I don't know, but I tend to think that many of the chronic problems during this COVID lockdown and COVID pandemic has been neglected. So a lot of people have not been getting regular supply of medicines. They have not been going out of their residences, or often not getting proper supply of the medications. And at times they were careless also. So I think we have a lot of people whose hypertension has gone beyond control during these episodes, and so it can be expected that patient has had some increase in the incidence of stroke. But really, we do not have any data as yet to tell you that the stroke cases have increased or not. And another thing to be highlighted is that coronavirus infection is a prothrombotic state. So anyone with background hypertension and other risk factors, if afflicted with COVID-19, I mean, it is the chances of sustaining a stroke. There are some initial reports that the major presentation in a COVID-affected patient has been stroke. So, like myocardial infarction. So, stroke can be one of the presentations in a person afflicted with coronavirus also.
Fine, sir. So one question is chronic stage of ischemic stroke, which is safely used to decrease systemic blood pressure, calcium channel blocker or ARB or CCB plus ARB? What is your opinion, sir?
You see, I mean, each molecule has its advantage or some kind of disadvantage. If you uh, call me which is the most reliable and the group of molecules, then it is definitely CCB, and they are associated with least blood pressure variability. So one CCB is a must for any patient who has suffered a stroke, and diuretics are the next group of molecules which are also associated with the least blood pressure variability. On the other hand, I have showed you that the RAS blockers are somewhat protective for the brain. They protect the blood-brain barrier. They can have some action against the reactive oxygen species or the oxidative stress. So my suggestion to you in the first line to use a combination of a RAS blocker plus a CCB or a RAS blocker plus a diuretic, not to go for a single drug. Then if the blood pressure is still not controlled, then go for a triple combination of a RAS blocker plus a CCB and a diuretic. So that is the way I will advise.
Fine, sir. Sir, one more question has come. Doctor said good presentation. Then he said, in your opinion, sir, which ARB offers stroke protection in hypertensive patients? What is your experience?
No, I mean, I don't think the molecules have been compared face to face with regard to stroke prevention. We have one trial with perindopril in the progress trial, and you will find a mention in the textbooks that perindopril has been recommended for secondary stroke prevention, perindopril plus indapamide, but that is a ACE inhibitor, not a ARB. As far as ARBs are concerned, I think all ARBs are equally good. But as I told you, that telmisartan is the one which is being studied recently in terms of prevention of vascular dementia. So, I mean, and telmisartan, as you know, in the on-target trial was shown to be at par with ramipril in terms of long-term prevention of vascular events. So, telmisartan is a good ARB to bank upon. It has the largest volume of evidence also. So, all ARBs are good, but telmisartan has the largest volume of evidence, and it is the one that is being currently studied for prevention of vascular dementia.
Fine, sir. Sir, next question is RBs are neuroprotectives. Which is more telmisartan or losartan or olmesartan?
I've just answered that question, I think.
Same, I think, yeah. So, okay, sir. Your comment on ARB as hypertension, vascular cognitive disorder, and neuroprotection.
I've just told you, I mean, studies are ongoing with regard to telmisartan, whether it can prevent the onset of vascular dementia and even Alzheimer's disease. But the study is in progress. It is just the say phase 1B trial. So we'll have to wait for some time. Right now, our focus should be on control of hypertension. For that, as I told you, in a patient who is at high risk, our focus now is on combination therapy. So you should start with a RAS blocker. It can be a ARB, it can be telmisartan. Start with a combination of a RAS blocker plus a diuretic or a RAS blocker plus a CCB. If that is not enough, go for a triple combination of a RAS blocker plus a CCB plus a diuretic.
Fine, sir. Sir, one final question which is sir, which lifestyle modification you advise for hypertensive patient to avoid stroke risk particularly? Your comment, sir.
You see, lifestyle modifications are the same for all patients having any kind of atherothrombotic disease, be it stroke, be it myocardial infarction, or be it peripheral artery disease for everyone. So, in terms of lifestyle, get rid of all your addictions, that is smoking and alcohol, they are the leaders. Then regular exercise, keeping your body weight in control, have an ideal BMI, and eat a lot of fruits and vegetables for regular supply of antioxidants. So these are the general lifestyle measures that and salt restriction, of course. So these are the general lifestyle measures that we suggest. And on top of that, one has to also resort to regular intake of blood pressure medications, control of diabetes, and control of your lipids for ultimately prevention of any kind of atherothrombotic event.
Thank you very much, Dr. Soumitra Kumar, for an excellent, lucid, insightful presentation, and particularly giving all the questions answer for our viewers. So, thank you very much for coming us for this evening for this webinar, sir. Have a nice day ahead, sir. Thank you very much.
Thank you, everybody, and thank you, Torrent team, and good night to everybody.
Good night, sir.
Thank you so much, Bansharaj. And
কোয়েশ্চেন একটাও নেই, সব আমরা বানিয়েছি।
জানি, তো সেই জন্যই তো চ্যাট বক্সটা নিজের কাছে রাখতে হয়।
না না, চ্যাট বক্স না না, এটা ভুল কথা আপনার। চ্যাট বক্স আমি ভাই,
না চ্যাট বক্স রাখতে হয় মানে কি
আমি জি, are you there?